Okay, we good to start.
Yeah.
Great. Okay, well, welcome back everyone to week 2 of MNDRA's State of Play. Just before we start, I'd just like to do an acknowledgement of country. So in the spirit of reconciliation, MND Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And I'd like to acknowledge the Wiradjuri people on whose land I am and pay my respects to elders past and present. So as I said, welcome back to week 2. As we said, these sessions are replacing MND Connect sessions, and we're actually bringing you our brilliant researchers right into your living rooms and offices. So today we're changing pace a bit, going from last week's exciting insights into how we actually model disease in the lab. And to this week, we're hearing about how we can improve care and decision-making for those living with MND. We'll hear from Professor David Berlowitz from Austin Health and the University of Melbourne, and from Camille Painter, also from the University of Melbourne. So please feel free to ask questions throughout the talk using the Q&A or the comment buttons. And similarly, if you're on Facebook, you can also ask questions through the comment section. We'll collect all those questions and we'll be answering them at the end. So we'll have a joint Q&A session at the end of the session after both of our speakers. So without any more ado, we'll get going, and that's enough from me. So first up, we'll be hearing from Professor David Berlowitz.
Thanks very much, Gethin, and thank you for the opportunity. All right, let me just do some screen sharing here. Okay, so my name's David Berlowitz. I'm a respiratory physiotherapist by trade. So my clinical work before they stopped letting me anywhere near patients was doing stuff like Caroline's doing here, putting people onto ventilators. And that's a really important part, as many people will know, of living well with motor neurone disease. So motor neurone disease, just the quick background, which is maybe unnecessary for many of you, but what we're talking about is a disorder of the neurological system that where the genetics are rapidly evolving, and what we thought previously was really spontaneous out of the blue disease is rapidly turning out to be related to different things in terms of environments and genetics. That means this incidence means that every 2 weeks, somebody in Australia, 2 people a week in Australia are diagnosed with motor neurone disease, which means there's between 1,200 and 1,500 people living, and it occurs in the 5th decade of life on average, but of course that spreads quite a bit. Respiratory compromise is a really important part of the progression of disease, and much of the work we've done, and I'm going to talk about, is around trying to modify that by helping people with their breathing. So my colleague and good friend, Paul Torman, we share the same birthday, but he is a little older than me, designed this phenotyping system, which is a way of categorizing people with motor neurone disease based on where their symptoms start and what the type of symptoms are. So we're very focused on that. Classical, what we call ALS, amyotrophic lateral sclerosis, with a mix of weak and overexcited spastic muscles. About a quarter of people start with that with their swallowing muscles. And another sort of group here of the sort of 65% of the total have some combination of their arms getting weak and their legs getting weak first. So maybe difficulty with fine motor function or tripping is the first symptom people remember. 9 to 10% of people have kind of floppy arms or legs. And then another small group have what's called primary lateral sclerosis, which is a real stiffness problem. But the important thing about those categories is that the disease progresses differently across them. This is Paul's work over many years, and it shows that people with primary lateral sclerosis, for example, that smallest group, live the longest, and that there's difference across all of these groupings here. When somebody with motor neurone disease starts to get weak in their breathing muscles, the first time this becomes a problem is during sleep. So when all of us go to sleep, we breathe less. But if you're not weak, it doesn't matter. You know, nobody notices. But you can imagine that if you're breathing while you're awake and kind of what we have called the alerting kind of stimulus to our motor function, if you're just kind of hovering along, being able to keep your breathing big enough when you're awake, but then you go to sleep, you can kind of fall off the edge a bit. And so this turns up in sleep much earlier than it does during the day. So this is a measure of carbon dioxide, so the waste product that's produced by your breathing. And when this person here starts to go off to sleep, that goes up, but it goes up more than it should. Their oxygen level here drops and stays low all night, and their sleep is terrible. This should have nice bits of blue and red, and it should be in big chunks. And what this means is that this person is waking up again and again and again, because perhaps not surprisingly, your body doesn't like to not breathe. So it wakes you up and says, "Oi, giddy up." This makes you feel really tired, and it's really not very good for you. But we know if we put people, and this is the same person, onto a ventilator to give them non-invasive ventilation, everything gets better. You can't actually see their saturation trace. It's so good. Their CO2, their carbon dioxide is flat. And these bits of red here, which were absent in the previous screen, that's REM sleep, rapid eye movement sleep, when you do all your breathing, or you're dreaming rather, or most of you dreaming. And this blue stuff, this is what we call slow wave sleep. And this is the stuff that makes you feel better. This light stuff, this yellow and green stuff that they only had the night before, or wasn't quite the night before, but previously, is now in much bigger chunks. This is a good night's sleep. I'd be happy. So non-invasive ventilation, on that first page, you saw the mask that the man was using, Caroline was putting on the man. It's connected to a machine that doesn't give you oxygen. It just makes you breathe overnight at the same amount you breathe during the day. So it just keeps your breathing at that same level. It doesn't stop, it stops it from dropping off overnight. But that's enough. That's more than enough to make you feel better during the day. And we know here, there's not a lot of data about quality of life, but we know here that this is a rating scale of how severe motor neurone disease will be. And it's a progressive disease. So the line is going down across the screen. But the measure of a generic quality of life or disease-specific, sleep-specific quality of life, they go up and they stay up despite people's motor neurone disease progressing. Now, when we do clinical trials, we do randomized controlled trials. They're the best quality trials. They're the ones that we're seeing appearing in the newspaper around the vaccines with their beautiful success rates that we hope will mean that we can all get out of our bedrooms. And we've done that in motor neurone disease, but we've only done one randomized controlled trial, and it was tiny. So this is the famous study by Burke from a number of years ago, where only 41 people were randomized to get NIV or not. And what they found, pleasingly, was that there was a survival advantage in the people who got non-invasive ventilation. They lived for longer than people who got standard care. And this is a big difference. Most of that difference was in fact due to the group who didn't have any trouble with their swallowing muscles. They got the most benefit in this study. But there's a problem with this study, which is that in the control group, by chance alone, because it's so small, they had 1, 2, 3, 4 deaths in less than a week in the control arm, which means that these curves, which is kind of the measure of goodness, moved apart really fast. And so it's likely that this is what we call a false positive result. It doesn't mean it's not true, it just means they fluked it with really low numbers. And so what it might also mean is that this finding of no difference is perhaps not true. So we went on to check whether the phenotyping that we talked about before affected how much benefit you got from non-invasive ventilation. At this stage, this was usual care, so you can never do that randomized control trial again. We have no clinical or ethical equipoise to ever do that study again. We couldn't randomize somebody to not being able to use NIV, but not everybody does for a whole bunch of really good reasons. And so that allows us to do what's called a cohort study. And so 20 years ago, we started this. And in fact, the data goes back 25 years. And all we wanted to do, but it does take a long time, was to look at the effect of non-invasive ventilation on survival in a really big cohort, in a really comprehensive cohort, and to see whether it's different across those groups of patients. So I'm from Melbourne. The clinic at Bethlehem is the big one. It looks after most people with motor neurone disease in the state. And we collected data on, as you can see, almost 1,200 people, some of whom we had to exclude, as you always do, but we actually included 929 people in this study. So that's really a very large study, and we followed them out until 2011 was when we stopped. And the data actually dates back, as I said, almost 20 years. So the people who chose to use NIV, remember this is not a randomized controlled trial, they weren't allocated to one group or the other. This is what they chose. They tended to be younger, as you might imagine. More of them were men than women. More of them had riluzole, the only drug we've got, well, at that stage. More of them also chose to have feeding tube assistance, and the difference in the groupings were quite different. There were many more people with bulbar dysfunction who did not choose to have NIV between the two groups, and you can see that the other groups were slightly different as well. But within the groups of NIV or no NIV, the spread proportionally is kind of similar. NIV worked. We found that the difference in survival between the two groups was almost 13 months, 12 and a half months. 12 and a half months. And this is a big hazard ratio. It's a 39% chance of doing better. So that's what that curve looks like. If you think back to the other one, where red is having the ventilator and blue is not, there's a big difference here in the proportion of people. So that's 100%. And this is time since symptom onset. So this is how many months it was. When we looked within the phenotypes, we could see that the people who had trouble with their swallowing actually had the biggest improvement. There's a very large difference here in median survival. And those are just the graphs that kind of follow on from that. Now, there are 4 other cohorts now, including one that was just published. Well, sorry, it's just been accepted for publication, and just wrote an editorial, which is why I can share the data, because it's coming out, I think, this week. The difference here is seen in all of these groups. It really does work, and importantly, how much you use it seems to matter. We didn't have those data, but a couple of these other groups did. And 4 hours seems to be a magic number for how much you need to use it to get benefit. And you really can sleep this well with it on. People who, you know, those of us who do this are good at it, and the centres that do it are good at it. We have all slightly different models, but we work together. We're all on a big trial together. If people are able to tolerate it, it's a good thing. Now, I'm just going to divert off slightly into basic science land, the place where I'm not an expert, but we've always wondered how it might work. And there is now some data that suggests how this might produce the benefit. When your oxygen level drops when you underbreathe, so that goes down, then what happens is you tend to wake up and take a big breath, and it quickly goes back up to normal. That process is really damaging for your cells. That reperfusion injury is what it's called, where the oxygen rushes back into the cells, produces a lot of very reactive oxygen species, which are bad for cells and seem to be particularly bad in motor neurone disease. And so people have done experiments where they've taken mouse models of motor neurone disease. There's another paper that I haven't talked about here that showed that it applies to genes as well, and mimicked sort of sleep disordered breathing in the creatures, and showed that they got more rapid disease progression. So what probably happens, well, no, what I hypothesize happens, we don't have enough evidence for this yet, is that the sleep disordered breathing sort of potentiates the damage that's occurring because of the genetics or whatever else has given you this thing called motor neurone disease. It adds on top of it and maybe makes it roll along quicker. And that conversely, by taking it away, maybe you unpack some of that kind of almost gain in the system. So we've produced in Australians evidence that it really is a very big deal. It's probably the biggest deal in terms of survival in people who have swallowing difficulties. And that's in part because without it, you get into strife pretty quick. But it is difficult technically to get it to work, and it requires a lot of collaboration between the therapists, all of the clinical team, the family, and of course the person living with motor neurone disease. So I'm going to stop there and just leave you with the fact that it works. So we should always consider it, and it's a really important thing. And say thank you to Paul, to Susan Mathers, who I've also worked with for over 20 years. And this is the VRSS crew, the Victorian Respiratory Support Service crew. That's Mark Howard up the back, who's the director, and he's not tall enough to be up the back. I'm not sure why he's there. And a bunch of the physios and nurses and outreach folk and a whole, you know, it takes a village to do this kind of thing. Thanks very much.
Thank you, David. A fantastic overview of the NIV. We'll just go directly over now to Camille, who's going to talk to us about her research, and then we'll come back after Camille's talk to have a Q&A session. So please keep firing your questions in if you have anything you want to ask. All right, take it away, please, Camille.
Great, thank you. And I will do my screen sharing thing. And yes, David set a high bar there. Lovely presentation. Thank you very much, David. And thank you for the kind introduction, Gethin. Very excited to be part of State of Play. Before I start talking about decision-making in M&D, I'd also like to acknowledge the traditional owners of the various lands that we're meeting on today and pay my respects to elders past, present and emerging, and acknowledge and celebrate the diversity of Aboriginal peoples and their continuing connection to their culture, country across Australia. So this evening I'll be talking about the results from my research looking at healthcare decision-making in MND, and this is part of my PhD research, which I've been doing for the last 3 years. I would like to acknowledge and thank my supervisors, Professor Adam Vogel, Associate Professor Madeline Cruz, and Drs. Susan Mathers and Heidi Gregory. And also like to greatly thank the MNDRA for jointly subsidising my PhD scholarship and providing me with a top-up grant. So healthcare decision-making in MND, why is it important? Well, engaging patients in their healthcare through shared decision-making is a really fundamental principle of patient autonomy and patient or person-centered care. And person-centered care is considered best practice, and it's especially important in complex medical decisions such as MND, where the clinical focus is symptom management and quality of life. We know that shared decision-making often involves family or informal carers. It requires a willingness for people to engage in healthcare as well as competent communication and cognitive abilities. Now, research in other disease groups has shown us that communication impairment can be a barrier to shared decision-making. We know that many people with motor neurone disease will develop a communication impairment, primarily a motor speech impairment called dysarthria. And it's also reported that some people, between 25% and 50%, will develop behavioural or cognitive difficulties. The motor impairments impacting people's upper limb also impacts people's ability to engage in written communication. So they will have trouble writing and typing. So all these create barriers to independence. So the aim of my research is to gain a greater understanding of the complex and multi-dimensional nature of how how individuals approach decision-making, and to identify how it might be affected by communication or cognitive impairment, so that clinicians can provide better patient-centered care. So this, the design of this research is a longitudinal qualitative study. I interviewed participants up to 3 times over 22 months to gain insights into the lived experience from people living with MND and a family member as they engage in healthcare and health information to manage their disease. So the numbers might be small in comparison to the quantitative studies, but the data is rich. And tonight I'll be talking about the results from the analysis I've done on the first lot of interviews I conducted. So the interview transcripts were analysed via a method called thematic analysis. So I'm not analysing for statistics, but I'm interrogating the interview transcripts to consider a particular issue within cases and across cases to identify similarities and differences within the group. Now, for people in the audience who are personally impacted by MND, this information may not come as a big surprise, because I interviewed people living with MND and carers about their experiences. I hope a lot of it does ring true for you. However, everybody is different. So there may be issues that are different for you or issues that are not mentioned in these results. And I guess this is a recognised limitation of this methodology. It describes in depth and in detail the experiences of those people in the sample, but it's not designed to describe the experiences of all people living with MND. So this is the sample of people that I recruited for the study, which was 19 people living with MND and 15 carers, all from a multidisciplinary specialist clinic here in Victoria. There were 9 women and 10 men with an average age of 63. And you can see here we've got quite a range of years post onset of symptoms. So someone that was only 1 year post symptoms beginning and someone 17 years post. There's a spread there of the MND phenotypes that David already explained. And 4 participants were nonverbal communicators. So they communicated either by writing, typing, or eye gaze technology. And in the study, there were 15 carers, 10 women and 5 men, with an average age of 59. So the analysis identified 6 overarching themes: dimensions of decision-making, window of opportunity for choice, intrinsic and extrinsic influences impacting decision-making, planning and uncertainty, and communication is core. So I'll talk through those results, and I'll also talk about the implications. So what can we learn about this, and what can clinicians sort of take away? So interestingly, many people living with MND perceived a lack of clinical decisions to make. And some participants felt that there were no decisions because there was no choice. And this really related to a lack of treatment options, or because the disease symptoms and progression, or the type of MND they had, really dictated the interventions that were necessary. This meant that for some, the decisions were primarily viewed as when rather than if to accept. And then so they weren't really conceptualized as a decision. The exception, because there's always an exception to the rule, was for participants considering early feeding tube or PEG placement, where considerable deliberation with carers and advice from the specialist clinical team occurred. Now, the context, just for those of you that may not be familiar with clinical management, is that the specialist clinic will offer patients with deteriorating respiratory function early PEG placement or early feeding tube placement. And this allows for insertion under sedation, which may not be possible later in the disease. So this consideration of early feeding tube placement meant that for some people without swallowing problems or dysphagia, they needed to make a decision about a feeding tube. And that's really quite unique, because in other medical areas, most people deciding on feeding tubes do have swallowing problems. The participants in this study facing that decision often waited until disease progression forced a decision, or else they relied heavily on the healthcare professionals to guide them through that decision making. And the importance of the specialist clinical advice was particularly strong in this area of early feeding tube insertion. However, despite this context that people are saying they felt like that the disease was really dictating the decisions that they had to make, there were sometimes opportunities for, or windows of opportunity for choice, which is the second theme. And this was the time between receiving information or recommendations about interventions, which is done likely as a precursor for expected functional decline, but before the disease progression necessitated their implementation. So for some participants, this gave them an opportunity to choose. However, for some participants, the fact that these issues were brought up early and this information was received early came at a cost of quality of life. They really felt it was burdensome to find this out. So clearly there's a fine line between providing information in advance so that people living with MND can have an opportunity for enhanced control over their choices, and the emotional costs that this may incur. So symptoms and the type of MND people have does dictate the timeframes of interventions that are necessary, and the information from healthcare professionals that have a duty of care to provide, to make sure that patients are making informed choices. They want to minimise risk, want people living with MND to be physically safe and emotionally prepared. So judging the optimal timing of providing all that information without overwhelming patients can be challenging. Certainly the way that healthcare providers provide that information can have an impact to enhance engagement. And I'll come back to that when I'm talking about communication is core, that our last theme, because some nice information came up there about participants reporting about the communication style of healthcare professionals. When we looked at the factors that influence decision-making, we identified intrinsic and extrinsic factors. So the intrinsic factors were those sort of internally driven, such as acceptance of diagnosis and prognosis and personal decision-making style. And some participants deliberately chose to be very independent and not involve others in their decisions. And I thought that was especially interesting because I think as a clinician myself, I'm a speech pathologist by background. I think there is an assumption that if someone has family, that they're naturally going to involve family in decisions. Other people reported, they collaborated as a family and they collaborated a lot. And that was particularly so for patients and families that had scientific or medical backgrounds. So I think the implications for this as clinicians is that we don't make assumptions about people's decision-making styles based on your living situation. And also of course, having the patient's values at the core, but just thinking of how the family might be making decisions, and that collaborative nature of decision making, where sort of more of a family-centered approach and providing information consistent to all the family will be important in that area. The extrinsic factors that we identified involved support from spouses and family members, as well as the support from the specialist clinic and financial security. So of course, spouses and families provide a huge wide range of support, but I was specifically looking at what support family members provide in relation to healthcare decision making to help people living with MND remain involved and engaged in healthcare. And in this case, families provided informative and practical support. So carers sought and shared healthcare information, they organised healthcare appointments, they translated where communication impairment was present, and they assisted a lot with communication devices. And this support was essential for people living with MND to maintain engaged in their healthcare. Carers made deliberate decisions to prioritise family members and assist them to maintain engagement, but sometimes that did come at a personal cost for them. So carers reported that they limited their other responsibilities or their hobbies in order to achieve those commitments. Carers' capacity to support family members but sometimes was constrained by employment. So people might have trouble getting time off work to attend clinical appointments or be home when the Motor Neurone Disease Association advisors come. So that meant missing out on information and education. And both of those are likely to be barriers to collaborative decision making. Our fifth theme was planning and uncertainty. So both people living with MND and carers reported uncertainty, which challenged planning and anticipating future care needs. Now, this uncertainty was expressed independent of disease duration. And the concepts of some uncertainty were primarily related to disease trajectory. And we thought that was somewhat surprising given all the participants were seen by the same team, which we thought would eliminate factors contributing to variation. Now, we didn't obtain the perspectives of healthcare professionals for this study, so can only speculate as to this uncertainty. And participants might be influenced by information they see on the internet, celebrity faces of MND, or personal experiences. Information provision might be ambiguous. Patients are provided with a combination of population-specific as well as personally specific prognostic information, and perhaps they do have difficulty differentiating between that. Or the experience of living with a life-limiting disease may well feel uncertain, even if the disease trajectory has been explicitly explained. So our last theme, but certainly not least from the speech pathologist, is communication is core. So communication plays such a significant role because it's our agent for patient autonomy. People living with communication impairment reported how it impacted the quality and quantity of their communication. So people reliant on writing or communication devices are conscious of the time-consuming nature of interactions when using alternative communication, particularly in a busy clinical environment. And they reported sometimes their answers might be more brief, or they didn't ask as many questions as they otherwise would have. People have a communication impairment, need strategies and support to ensure they remain involved. And one of the strategies participants reported was that they would prepare for medical appointments by writing things down or discussing issues with family members in advance of appointments. People with communication impairment really do rely on the support of others. Unfortunately, one participant even reported an instance where a healthcare professional who was unfamiliar with the communication device was unable or unwilling to use it. People dependent on communication devices require the physical or logistical assistance to set up and use that device, which is mostly provided by family, often because they could be in healthcare settings with healthcare professionals who are unfamiliar with them, illustrating the need for support and care that is available and skilled. When I looked at the data for issues around communication, it wasn't just about communication impairment. It comes back to that point I alluded to earlier. Participants reported that the communication style of healthcare professionals also influenced engagement in decision making. So participants said that if healthcare professionals presented information with qualifications like if or should, like if you need this down the track, or you don't need this now, but I want to show you this eye gaze device should you need it later, that really helped them stay engaged. So there are implications for clinicians with regard to healthcare communication. Firstly, that people living with MND and a communication impairment who rely on writing might benefit from advance notice of appointment goals so that they can prepare. And secondly, clinicians should certainly consider the language choices when presenting prognostic information, as well as using patients' personal communication devices and strategies. So that's the end of the results, and it's important to mention just a couple of limitations. Sorry, not there yet. Limitations of the study. So the limitations are firstly that the experience of healthcare professionals isn't represented here, nor are the experiences of people living with a cognitive impairment. Secondly, these results may not reflect the experiences of people living with MND who don't attend a specialist clinic with a multidisciplinary model of care. And lastly, only English-speaking participants were recruited to the study due to a lack of funds available for translating interviews. So therefore, this limits the cultural diversity of the perspectives obtained. So to conclude and summarise, decision-making is dynamic and patients and families may have different experiences between clinicians and between appointments. Some people perceive there are no decisions because there's no choice, and that appears related to the fact that there's no treatment options or because the disease is dictating the interventions required. Although the exception to this is for people having to decide on a feeding tube early, and the specialist clinical advice is really helpful for them, particularly for people without swallowing problems. There's a challenge for healthcare professionals to find a right balance when providing information early. And we really need further research in this area to identify the appropriate time for each patient and each family. But we can see here the importance that the language that healthcare professionals use when providing this information is so important to encourage that engagement. We've seen also that some people living with MND might choose not to involve others in their decisions and be independent. So it's important we don't make assumptions. And that patients and families with a medical or scientific background are more likely to collaborate with each other outside the context of clinical appointments. A lot happens outside of clinic. And therefore, it might be more appropriate to have a family-centred approach. And finally, communication impairment can be a barrier to involvement in healthcare decisions. And we've shown that strategies and extra supports needed from carers and healthcare professionals to ensure that people living with MND remain engaged. So that's the conclusion. Thank you. That's the conclusion of my talk on MND. I'd really like to thank you for listening and attending. And I sincerely want to thank all the people that participated in my research, as well as the assistance from staff at Calvary Healthcare Bethlehem, who assisted with recruiting participants. So I'll hand back to Gethin, and I think we'll have time for some questions perhaps.
Great, thank you, Camille. And thank you to you both. That was two fairly different aspects of care, but both really critical to ensuring that we look after our patients as best we can. I have a question come in here which kind of crosses both of your areas of study. So we know that people resist getting feeding tubes. Are people also reluctant to try an IV too? Do you have any insights into how you can persuade or encourage people to try an IV?
Yeah, thank you for that that question. So, I mean, a lot of the answer to this was contained in Camille's presentation, to be fair. An option presented early in the journey is good. Disclose early, disclose often, if and should, I think was a really nice way of talking about it, Camille, because it's the same kind of conversation. How NIV is, information around NIV is presented to a person with motor neurone disease and their family and carers and others, in many ways is dependent on the entry pathway. So a multidisciplinary clinic will have an approach. They may, the clinic that both Camille and I know best, have respiratory physicians kind of integrated into the clinic. Our outreach staff are there, but that's not the case in every clinic around the country by any means, or internationally. So there's some of these elements of model of care that affect how people have it presented to them. And it is absolutely a choice. It is, it requires a moderate amount of engagement by everybody to make it work. So it's not for the faint-hearted, and we've done work around trying to unpack that kind of burden versus benefit question. But as with all these kind of aspects of research, I think the key is to ask the questions. These research into clinical practice is to ask the questions that the people living with motor neurone disease want us to ask. And they're often around, certainly in our space, they're around this burden and benefit kind of question. So I don't feel like it's a thing that we necessarily persuade or encourage. I think it's a treatment option that it's really early to present to people. It's really important, rather, to present to people early on in their journey so that they can then come back and ask questions, they can do their own research, they can speak to other people who are using it, all of those kind of things. I don't know, Camille, I'm sure you've got stuff you can add to this.
Oh, just a little. I didn't specifically ask people about NIV, but it certainly came up when I asked sort of an introductory question around, have you made any decisions lately? And a number of people would often say, well, there was no choice there because I needed it. It was going to offer me some comfort. It made things easier. It made my breathing easier. I felt easier with it. Yeah, of course, I'm going to accept that recommendation. So there were a couple of people in the study that had difficulty with the mask, but no one explicitly chose not to accept NIV.
Yeah, and I think, and there are other benefits from it. Like one, people often talk about improvements in voice and other elements, because it can substantially increase your ability to project your voice. We know about that.
And their thinking skills. A lot of people said, I can concentrate better. I can, I can do my finances if I've had the NIV on overnight.
Yeah. Well, I mean, anybody who's had a newborn knows that that's what having bad sleep disordered breathing is like all the time. That awful feeling that you're really glad they grow out of? That's what sleep disordered breathing gives you, that horrible fog.
Thank you. An extra question to that is, I mean, in your initial study, David, I think you had something like 25% of your cohort took up NIV or opted into it. Do you have a similar take up now, or has it improved since it's become obviously a lot more established?
Yeah, the rates of use now are much higher. There's still a sizable proportion of people who, for various reasons, don't choose it. Don't end up using NIV. There's some, there's all kinds of reasons why you might choose no. A lot of it does come down, broadly speaking, as I said, to this kind of burden versus benefit kind of question. It's like most physical therapies. It's got to be worth it for you. Like, is it worth getting up and going for a ride on your bike tomorrow morning? If it's really cold and raining. All of us make these kind of choices all the time. And I think with physical therapies, perhaps more than, having a pill, the immediate kind of burden benefit stuff, like you confront it every day. Like every night when you go to bed, you have to decide if you're going to ask the person you live with to help you get your NIV on and sleep with it that night. So it is a movable feast. We have some data, showing that how much people use also changes variably over time as people get more or less benefit. We know if we start it too early, before people don't have any real symptoms, they find it hard to use, not because it doesn't work, but because they've got nothing to get benefit from. And conversely, some people who've been living in that fog that Camille talks about, when you give them the NIV, the next morning they go, oh my God, I thought that was just the motor neurone disease, but it is actually something you can fix. So, it very much comes down, I think, to how much it's worth it for you now.
Thank you. A question for Camille. Are there specific examples of words that probably health professionals should avoid, or words that are better to use when discussing these issues with patients?
I don't know that there's things to avoid. I think it's just framing things. So of course, always saying the truth, but I remember one participant's family member saying, to hear someone sort of say, well, when you need a hoist transfer, sort of just this more of a, and perhaps it's sort of about the style as well, as not just the words that you're using, but how you present that information. So when you need a wheelchair, yes, it might be that this person, it's likely that they're going to need a wheelchair, but if they're not using one right then and there, they don't necessarily want to hear it in that way then and there.
So can you, you've got a fantastic set of data there, from all that data, can you actually produce sort of specific tools or advice for other health professionals? I mean, obviously you've got a great idea how to do it, but can you produce sort of tools for wider distribution to really translate that knowledge into practice?
Yes, perhaps, although when you think I got this information from people that were very happy to participate in my study, and I interviewed them, and as a clinician, we're interacting with people every day, and with clients every day, and we can ask them, well, how do you like information provided? Do you want just black and white? Do you want the facts? Or, how do you normally seek information? How do you like to hear it? So that's certainly one way, because it can be very individual. And that's certainly what we saw in the study, that some people didn't like hearing that information too early. And we know from the research too, that often family members want to hear that information before patients want to hear that information. And there is a tension there. And this is not my research, it's some really nice research from a number of other people who have, documented how family members often feel more in control when they know what's going to happen. People living with MND don't necessarily feel the same. So I think it's really important, to have a discussion about who wants the information. You don't have to be in the same room or the same time to receive it. As far as producing something, I guess I'll be publishing the results of tonight's presentation is soon to be published, which is exciting. And I'll have some other papers next year looking at different angles of the data. So there'll be a paper specifically looking at communication impairment and what we can do around that to help facilitate decision making.
And David, do you find that there's cost is a barrier at all to accessing NIV?
Yeah, so yes and no, and it keeps changing. So in Victoria, we have a state-based service. So the Victorian Respiratory Support Service looks after everybody who needs a ventilator in Victoria. We have 1,000 people at home on ventilators. Obviously, a big chunk of those people are people living with motor neurone disease, but that's all kinds of folk. And so the state government provides for the equipment and the staffing and the maintenance and all those kind of things. I know in New South Wales, it has been very variable across area health services in the past. South Australia has had particular schemes. WA have different schemes, and Queensland have different schemes. Apparently, we live in a federation. Oh, and there's Tasmania too. So all of these things can be different. Recently, ventilation was included into as one of the items that you could spend some of your NDIS package on, which is great because that provides a minimum level of cover. But as I was kind of implying, there's also some issues around the model. And so it's not just about the device and the mask, it's about the support to ensure that people can use it as best as they want to. So it's really quite tricky, I think, to answer that question completely, because the devil is in the detail. The short answer is no, cost is not a barrier. And the real answer for some people is that it does matter.
Thank you, David. Another question here for Camille. Did any of the participants in your research study comment about the nature of the first communication to them that they had MND, their first diagnosis? Do you have any thoughts about perhaps how that could be done better? And this may be more applicable to, say, regional patients who quite often have to leave their city specialists and return to the regions where they don't have the advantage of perhaps seeing a multidisciplinary teams and perhaps are just dealing with a local GP. This is a topic that we've already discussed today in another forum, actually, but I think it's something that's very, very important at the moment.
There is a lot of information published about how people react to receiving diagnosis of any progressive neurological disease. That's the area that I know best. And there's also a lot of information about how medical professionals can provide that information in a supportive way. It's not something that I have experience of. It's not something that I'm involved with. And I think that the journeys that people have when they receive that diagnosis is really varied. And some people have really quite, well, pleasant is probably not the right choice of words, but they have a good experience with it because they've got supportive and thoughtful doctors or neurologists, and other people have had a poor experience. It's not really something that I touched on. People anecdotally sort of told me about it as at the beginning of the interview, but it's not something that I sought to get information from because it's already been published quite widely.
Cool, thank you. And another question, sorry for Camille, is we have a comment here saying they were quite surprised by the finding that scientific families collaborate more. How did you reach that conclusion, excluding other explanations such as, say, general education level or socioeconomic background? Did you manage to exclude those potential confounders?
I didn't try and exclude those, and it's a small sample, but generally people, of course, people with a scientific or medical background are going to be better educated and generally have a better socioeconomic status. So it is skewed in that way. But there was, a lot of discussion sort of as a family that, that seemed sort of quite particular to that group, where there'd be, journal articles researched in their own time and discussions outside of the clinic that then these families would go to clinical appointments and say, oh yeah, we've got this, can we talk about it, with the doctor? So because it wasn't something that I was specifically looking for before, this is the thing with a lot of qualitative studies, you look at the information that people have provided you and see what's there without, I didn't want to go in with too much of a preconceived idea. And I would probably have to go back and see whether, certainly that collaboration happened most with people with that sort of background and less for people without a medical background. Some, where people without that knowledge, and I guess it's not really that surprising, people without a strong medical or scientific background were more reliant on the expertise of their clinical team.
Thank you. David, another comment or question actually. So do people who perhaps already had sleep apnea or poor sleep habits anyway, are they more susceptible to developing MND? Is there any data on that?
No, there isn't any data on that really.
Okay.
We have had a couple of people over the years, as you could imagine, that had sleep apnea, and often it's actually got better when they've got motor neurone disease because they lose weight. So because of the kind of median age of people when getting sleep apnea being sort of 40s upwards, you could imagine that some people have got a degree of sleep disordered breathing for, you know, for the reasons that particularly men get sleep disordered breathing, but then have actually at least one particular person I know of had actually got a little better initially and then got respiratory failure. So they're kind of they intersect, but they don't kind of talk to each other.
Okay. Right. One final question. This is again for Camille, but it may also come back to you, David. So do participants identify that there is a lack of information available to them to help with decision making and managing their disease more broadly or even specifically to NIV?
No, I don't think so. I think that, in fact, there's quite a lot of information out there on the internet. And that's the challenge, I think, for a lot of people, is to try and filter through what's legitimate information and you know, what isn't. And I remember a participant talking about he'd seen on the internet a stem cell research cure that would only cost him $125,000 if he went to China to get it. So, you know, there's a lot of information out there. And I think that's, you know, as I mentioned, all the people that I interviewed came from a specialist clinic. So they're probably a group of people that are getting the best information possible, whereas people that aren't linked into a clinic like that, to an expert clinic, may be at risk of not getting such wide-ranging and evidence-based information.
Right.
I hope that answers the question.
David, do you have anything else to add?
Not really, just to say that we know that multidisciplinary clinics confer a survival advantage to people with motor neurone disease. It's been demonstrated a couple of, you know, really, really nicely in a couple of really good studies. It can be up to a year's difference. And so that comprehensive care and the evidence-based practice that you get from those kind of environments matter, and they really matter in lots and lots and lots of domains.
Great. Okay, so that brings us to the end of today's seminar, State of Play. So I'd just like to say thank you to both David and Camille for a real fantastic overview of their research in the area of care. And it's really brilliant to see how we can really pushing back I wouldn't say the boundaries, but we're certainly making care a much better arrangement, and research like this is really helping with that. So anyone who's attended today, you'll be receiving an email with a recording of the video. Probably take a day or so for it to be processed. Similar to anyone on Facebook, you'll get videos become available, and please feel free to distribute that amongst any of your community. And again, I'd just like to say thank you to everyone for participating tonight and coming along. And I hope everyone learned as much as I did. And so now I'll just wish everyone good night and please enjoy the rest of your week. Thank you.
Thank you.